Okay, would you like me to get started? Or Cody, you're going to get started, you
Yeah.
said, right?
Hello, everyone. Welcome to the Active Aging Rehab and Fitness Summit. Really appreciate you being here. I'm Cody Sipe, the co-founder of the Functional Aging Institute, and really excited that you're here for this specific talk on multifactorial falls prevention for older adults with Dr. Jennifer Vincenzo. We actually connected because we're both here in Arkansas, and she is the leader of the Balance and Fall Special Interest Group with the APTA Geriatrics. So definitely I get a lot of great content from her. Not only is she's a physical therapist, but she also has a PhD in exercise science. And of course, being an exercise physiologist myself, I love that combination, love that background, especially as it pertains to older adults. Her focus really is on geriatrics and fall prevention. And so I'm excited that she's here. And also the talk that comes after her, Erica DeMarch, she's going to be focusing in on more kind of one-on-one strategies, working with people that are at high fall risk. And Jennifer and Erica work together to make sure their sessions really kind of collaborated and meshed with each other. So I really appreciate that. And I think with these two sessions, you're going to get some really great evidence-based advice, but also some really good kind of clinical and professional insight as well that I think is so important. You know, one of the things that has been on my mind lately, I've talked to Dan about this, we've talked to a number of people, is what's going to happen as we kind of come out of COVID, because you know there's potentially a spike in falls that we're going to see, and even though falls are increasing, you know, what are these lockdowns, the social distancing, the inactivity, you know, how is that potentially going to affect our older adult population, specifically related to fall? So I think this is an awesome way to begin, and this is an awesome way to start to try to make more connections between physicians, therapists, and fitness professionals in this area of fall prevention and balance enhancement. I mean, let's face it, there's so many people that need our help. We need all of us working on this together, synergistically, you know, following these evidence-based guidelines. So I'm really excited about what we're doing. So Jennifer, thank you so much for being here, for contributing, and I will turn it over to you.
Thanks for having me, and great introduction about the importance of being involved in falls prevention from multiple providers that work with older adults. And before I start, again, I'm speaking to, I know, a very broad audience. So just kind of know your scope of practice and the things you can and can't do within your licensure and within your state. But I'd especially like to say that for fitness professionals, exercise specialists, and PTs, that we definitely can work together. If a fitness professional contacted me and told me they had training and experience in working with older adults, that definitely would lend me to want to collaborate with them, because we can't see patients, you know, all the time and after their insurance kind of denies them, or we can get them to a certain point where they're independent but not necessarily at their optimal level, which fitness professionals can continue to work on, and we can't necessarily work on that under insurance, guys. As far as PTs, I think to build a continuum of care, it can go the other way, us reaching out and finding out who in the community is able to work safely with older adults, and how can we bridge that gap. So today, on a second, my little clicker here isn't working. Apologies. So my acknowledgments here were that this presentation was also partially developed with APTA Geriatrics Balance and Falls. As you know, I'm the chair of that. And I was involved in developing with some of this content as well. So I really want people to understand what multifactorial falls prevention is, because it's not just about balance, strength, and walking. It's definitely more than that. And then using a specific intervention or assessment called the Steady, we'll talk about later, how to perform different aspects of the Steady, and then looking at other parts of that falls screening as far as medications, and like I said, not just balance. Consideration for other outcomes measures, and then thinking about when do we refer When do we as clinicians or exercise specialists need to send the patient to for more medical management of falls prevention? So first, let's talk about the definition of a fall. Not everybody completely understands that because it's not just going to the ground. It's actually an event, unplanned, that leads to an unexpected contact with a supporting surface. So that could even mean somebody going to sit in a chair. If you work with older adults, you might see them kind of stumbling, losing their balance and falling into a chair, or kind of bumping and falling into the wall. If the wall wasn't there, they would have been on the ground. That is actually a fall. A fall isn't, in the case of an older adult falling, we wouldn't call it necessarily if someone pushed them, because we couldn't prevent that. So if they fell because they had a stroke or a heart attack, that wouldn't necessarily be counted because it wasn't preventable. Sometimes older adults don't really think about, stumbling, slipping, or tripping as a precursor of a fall, or even as a fall if they go into a chair imbalanced. So this can be helpful, having your older adult look at this and see if any of these describe them, especially this grade 1, we're talking about a near fall. These are the people we definitely should be working with to prevent the falls. They may get multiple slips, trips, or losses of balance, are catching themselves right now, but as they age, and if they don't maintain their strength, balance, walking function, then they're going to be to that grade 2 where they fell and hopefully didn't need medical attention. But you can see there's different grades, which is nice to refer to. Why do we care about falls? It is the primary cause of death related to injury, morbidity, mortality, loss of function. It is a big impact in people as they're aging. And we want to do what we can to prevent it because many falls are preventable with appropriate interventions. The other thing I want to briefly discuss is to consider engaging in a broader realm in falls prevention every year. So just last month, the National Council on Aging has Fall Prevention Awareness Week. So it used to be a day, and it's increased to a week, which is the first week of fall of every year. And the National Council on Aging works to have activities and promote other organizations to raise awareness and do things about falls. You can look on their website. They have a lot of wonderful resources year-round, but around that time of year, they also have a lot of things to help you engage. And how can you be involved? You can attend health fairs. You can do community screenings, which is what I tend to do. Just opened community screenings to make older adults aware and tell them what they can do to prevent their risk. And even do in-services at retirement facilities or senior centers. So when we talk about falls, we talk about screening, we talk about assessment, intervention, etc. So what is screening? Screening is a quick way of looking at something to see if you need to look at it further. It can be performed by anyone, and it's quick. It's usually less than 5 to 10 minutes. Again, it's to determine, do we need to do anything more for this patient to determine if they have a higher risk of falls. And it has high sensitivity, meaning it's going to flag a lot of people that need assessments, but not necessarily people that are truly at risk of falls. It's not going to rule out people very quickly. If somebody screens positive, then that means we need to do an assessment. And that's where we look individually at what are their individual risk factors and what can we do to address them. As far as physical therapy, we have clinical guideline statements that are a conglomerate of the American Geriatric Society guidelines, the NICE guidelines, etc. So some of those clinical practice guidelines are already in place. And for PTs, we're supposed to screen all older adults every year that we see. Older adults are over the age of 65 generally is the term. That's not to say that you certainly can't do this with younger people. You want to ask them if they've fallen in the last 12 months or do they feel imbalanced. If they've had a history of falls, then you should watch them walk to determine if they have balance impairment. And a screen would be positive if they had a history of multiple falls, even if when you watch them walk, they do not have balance or gait impairments, or if they've only had one fall and a balance or gait impairment is observed. So again, that screen, that's a quick way to look at it. Then we have to do a more in-depth assessment. After this positive fall history, so your patient has said, yes, I have fallen, we almost have to play detective. So why did they fall? We want to look at their symptoms at the time and ask them, what was going on? How did you feel? Did you feel odd? Did you start to feel lightheaded, dizzy? Is there a reason you think that you lost your balance? Have they had a history of previous falls? Again, we asked that. Where did it occur and what were they doing at the time? Was it a time of day? So was it AM, PM, mealtime? Had they taken medication, etc.? And then did they have any trauma, even bruises? Oftentimes, if people suffer a fall, they may become fearful of falling and restrict their activity, which actually puts them at a higher risk of falls because they're not as active. So we definitely want to ask them that as well. So that's termed SPLAT. Symptoms, previous falls, location, activity, time of day, and trauma. What I want to also focus on is the CDC Steady Toolkit, which is a toolkit to assist clinicians and other professionals to conduct multifactorial falls assessment within their scope of practice. And STEADY stands for Stopping Elderly Accidents, Deaths, and Injuries. It was developed by the CDC and an interdisciplinary team, originally for primary care. However, it is used in different clinics. Some therapists use it within their EMR. Some people use it in community screenings, and there's more implementation in other areas than just primary care. So this is what the algorithm looks like. Don't let it scare you. It does look a bit overwhelming. I really like the blue colors because that's one of my favorite colors. But besides that, what we want to do is we want to screen for falls risk yearly, or if a person says they had a history of fall. We can ask them 3 questions. 1, do they feel unsteady when standing or walking? Similar to the APTA geriatrics. Do they worry about falling? Or have they fallen in the past year? And then we'll ask those SPLAT questions. We can also have them fill out a brochure here that I'll show you, which is basically a questionnaire. But basically, if they do screen not at risk, and I don't like that term necessarily, that would be screening not at an increased risk, because no one is not at a risk of falling. So we don't want to tell our older adult, hey, you did great, you answered no to these, or you got this score on the questionnaire, so you're not at risk of falling. That's actually not accurate. You're at a lower risk of falling than people your age, probably. So we still want to do prevention. That's really big. We want to recommend effective prevention strategies. So we want to refer to community exercise or fall prevention programs to continue to help them prevent it. And then we can educate on home safety and prevention. We don't want to assess vitamin D intake as far as physical therapists go or as far as exercise professionals go, because we don't prescribe, unless you have a license like a dietitian, we don't tend to prescribe supplements unless we've taken the blood and know. If we are positive for the screening, they're at a higher risk, we do assessments to further decide what do we need to do. Here's the variety of interventions. So you could see that falls are multifactorial. Again, it's not just balance, strength, walking. We've got in here, you could see medications, home hazards, blood pressure problems, vision, feet and footwear problems, vitamin D, and past medical history. I'm going to talk about that briefly here. The Steady Toolkit has a lot of materials for providers and patients. Not sure if you can click on these in your handout because it's a PDF, but if you can't, just go directly to cdc.gov/steady and you will see the slew of tools available, and everything's free. There's also an hour-long continuing education webinar that they have, which is free. I'm not sure about the CEUs depending on your license and state if they'll accept it, but it certainly is worth the training. There's materials for patients as well in English and Spanish, which is great, and all are free and printable online. Between when I finished this presentation and now, there's actually a interactive questionnaire online through the National Council on Aging. So if you type in your website, check your risk of falls and NCOA, that will come up. The older adult can put in their information, click, and then they will get a printable copy of that, and they're able to provide it to their healthcare provider. So this is that state independent brochure. It's really a fall risk questionnaire here. I'm just looking at the chat real quick. The CDC is CDC. Oh, yep, he just put it in. And then the NCOA is NCOA, check your fall risk. You would Google that. So basically that's this in an interactive form. I love this questionnaire. So it is based on research, but the reason I like it is because it's very kind of older adult friendly with the verbiage and with the why do we care. So we can see here if they've fallen in the last year and they check yes, why does it matter to them? Well, that's actually the highest risk factor for falling again. It makes sense, right? But of all the risk factors, if somebody suffered a fall, that's the highest one that indicates they're probably going to fall again. So that's a big reason to say, hey, that's the highest indicator. We really need to find out why and work on those issues. I also like to use this to kind of target what's the problem and what interventions do I need to do. If they've been advised to use a cane or a walker, it doesn't necessarily mean they're going to do it, right? So that might tell us that their doctor or somebody else has seen that they're unsteady, but they're not using it, or are they using it properly? So it's really important to make sure it's fitted to them and they're using it properly. If they feel unsteady, even if they don't look unsteady, that indicates they're at a higher risk of imbalance and falls. If they're holding onto the furniture, also a sign of poor balance. And then you could see, this is a nice one here. I need to push up with my hands to stand up from a chair. That's telling us really, they probably have some lower extremity weakness or power issues or imbalance, right? So it may target some of those impairments and say, okay, this is why they're at risk. And target on what we might want to do with that. So notice some other ones, rushing to the toilet. So rushing to the toilet or incontinence increases risk of falls. So in that case, we either need to refer them back to their physician if it's not managed already, or in my case, I'm a geriatric specialist, but I'm not a pelvic health specialist, but one of my colleagues is. So I would refer the patient to my colleague who's a women's health pelvic health specialist to see if they can help. Numbness, so peripheral neuropathy, not feeling their feet. While we can't fix that, and it usually can't be fixed medically unless there's a surgical reason, we can help them compensate by improving their balance or vestibular system in other ways. Medication is an issue, and in that case, we want them to be evaluated by their pharmacist or their doctor. And then if they feel sad or depressed, depression increases risk of falls. We want to make sure that they do see somebody for that. Again, do they see a counselor? Do we have to help facilitate that? So once our patient completes that brochure, and they can do it on their own, or we do the 3 key questions. Again, I'm a proponent of the brochure. They are actually a low risk if they score less than 4 points. Note that these first two are worth 2 points each because they put a person at higher risk of falls. I see a lot of times people count this improperly and use these only as 1 instead of 2. And then they need further screening if they're higher, so we can determine, is it a gait, balance, strength, power problem or not. The study suggests that we utilize the timed up and go 30 seconds chair stand and 4-stage balance to do those mobility and strength assessments. So for the tug, again, it's called the timed up and go, and you can look on the Steady website. There's a great video to show you how to do it. It's timing. How long does it take after we say go for the older adult to stand, walk 10 feet, turn around at a line, and then sit back down, and we stop the timer. It's important to know they should go at their usual pace. Some people erroneously do as quickly and safely as possible, but it's normal pace. So if they take a longer, 12 seconds or longer to do that, that means they're at an increased risk of falls. It's better at ruling in somebody than ruling out somebody who's going to fall. Now note, we don't just, you can also use means, but we don't just look at the time. That's really important to note. I've seen patients walk super fast, be 9 seconds, but be completely off balance. So in that case, they're at a risk of falling due to poor balance during the timed up and go, even if that score of less than 12 seconds indicates they're at a lower risk. To help you do it properly, an older adult to understand, demonstrate it for them once, and then you are allowed to allow them a practice trial. They can use an assistive device, and they can use their hands to stand up from the chair in this test. If they need any sort of help, or you feel like you have to stand next to them because they're unsteady, then that means that they're at a high fall risk. Another screen/assessment the CDC recommends is a 30-second chair stand. So we're looking at functional lower extremity strength and endurance. Again, there's also a video, but some great instructional manual or instructional pages here. So in this case, we want them in a standard height chair. They cross their arms, and we ask them first to see, can they stand up and sit down without using their arms? If they can't, then they can't perform the test. If they can, then we ask them to sit and stand repeatedly for 30 seconds, as many times as they can. And then we compare that to an age and sex norm here. So if they are lower than the age and sex norm, it indicates they're at a higher risk of falls. That's also telling you that their lower extremity strength, endurance, and or power, or even sometimes balance, may be an issue. But we still have to evaluate a little bit more, because potentially if the older adult doesn't have adequate range of motion at their ankle, they won't be able to shift their weight over their toes to be able to come forward to stand too. So it just tells us we need to find out, why are they having difficulty doing this? What's the problem? You are supposed to do it from a 17-inch chair. If you don't have one, just make sure you use the same chair every time. They aren't allowed to use their hands. If they do, they fail the test. And you have to count a full stand. So if the person doesn't stand all the way, it doesn't count. Another test is the 4-stage balance test. So that's looking at their balance in different standing positions that are more and more challenging. So again, there's a great video. There's a very easy handout to follow. Feet together, feet semi-tandem, tandem, and then single leg stance. But you have to go in that order, because once they aren't able to hold one of these positions for 10 seconds, they can't move on to the next. Ultimately, the test is, if they can't hold tandem stance for 10 seconds, they're at an increased risk of falling. Now you can move on to the single leg stance, and other literature indicates if they can't hold that for 6 seconds, they're at an increased risk of falling. And it is preferred foot forward, so it doesn't matter which foot is forward or back, and it's preferred foot elevated in the single limb stance. You can also allow them assistance to get in the position. You can have a chair in front of them and let them hold on to it, or they can hold on to your hand and then let go once they get their balance, and then you do the timing. So there's a study that determined that using assistance for the upper extremity and then timing it didn't change the relation to falls. So that's why we can do that. So the arms can be at the side or out to the side or across the chest, but any very large perturbation would be stopping your timer. Make sure you stand really close to them and guard them, because some people really lose their balance, especially during like the tandem or the single limb stance. Now you aren't supposed to let them do a trial before on these, but sometimes they'll definitely try and push you to if they don't do as well as they think. So you can let them do it a second time, but definitely take that first time because it's more indicative of their abilities. So if a person performs fine on all of those balance and mobility screenings, they're at a lower risk of falls. But if they do not do well on one or more of those, they should have what we call a multifactorial fall risk assessment. So now we want to know what's putting them at risk and why are they not able to do these things. And then we want to do interventions. So back to that Stay Independent brochure, right? That's going to help you determine some of those issues. Numbness, is there medication? So it's going to flag some of those, the risk factors, and help you decide what needs to be done. Review their fall history if that was an issue. If they say they feel lightheaded or dizzy, then we're going to check their blood pressure in different positions or look at their medication and refer them back to their healthcare provider to determine why that's happening. It could be a heart problem, it could be a blood pressure problem, or a medication problem. We're also going to review medications. I'll look at that. We can screen their cognition. We're not going to do an assessment because that's not one of our wheelhouses. We'll do a footwear check, check mobility aids, make sure they're using properly, and visual acuity within our ability. If your patient reports that when they stand or get up, they get dizzy or lightheaded, or they feel like they're going to pass out sometimes, or that's what they're saying, complaining of is happening when they fall, we want to check something called their postural hypotension or orthostatic. What that means is when they change position, their heart and blood pressure and vessels for some reason aren't accommodating that change and able to pump the blood up to their head. So there is a specific way to do it to get an accurate measurement. It's not just checking sitting and standing. There are time limits that you can see here. But basically it's rest, take the blood pressure and heart rate, and then have them stand and take the blood pressure and heart rate after 1 minute and 3 minutes. If the systolic drops greater than 20, or both diastolic and systolic drop greater than 10, or they're symptomatic, then it's a positive test. So you may have a patient you do this on and they don't have any symptoms. I honestly wouldn't be concerned if they didn't have symptoms. You didn't see any, they didn't complain of any. But note, the numbers are going to help if they're symptomatic, but even if they're symptomatic, those numbers may not be the end all be all. We also want to check their medications. That being said, we aren't going to recommend they take or not take anything, but we want to make sure they see their physician or pharmacist if they are on any of these medications that indicate it puts them at a high fall risk. There's a document that is updated regularly called the beers criteria. Unfortunately, it's not a list of the best beers or beers that older adults drink. It is a criteria of medications that should be carefully looked at and considered in older adults. And the ones that are related to falls are also on there. So you can imagine any medication that might affect the CNS or help people with mood or sleep are on there, or pain medication, because they can all make people sleepy. And those really affect older adults quite a bit more than they affect younger adults. There's other medications here, even Nsaids, and that is actually not necessarily for falls, but because it can increase people's blood pressure, unsafe amounts. So if you have an older adult who has high blood pressure and they're on antihypertensives, make sure they're also not taking Nsaids, or if they are, check their blood pressure when they're not taking them to see if that's affecting it. There's some great medication apps on phones and on websites that can help you with that as well. But again, that's for us to refer. Another consideration is any older adult taking 4 or more medications is at a higher risk of falls. And you can imagine that's a lot of older adults. So note that. Another screen we may do is a cognitive screen. So people with decreased cognition have an increased risk of falls. We can do things like, probably the quickest and easiest is the mini cog. It's just a three quick assessment. We're looking at 3 object recall and a clock drawing test, and it can very quickly determine, it's really dementia versus non-dementia. So it's pretty quick. It's not a specific test, but it's a quick cognitive screen. And if you can't click on these and you do from your PDF and you want the ability to, I'm happy to share some of the slides that are clickable with Dr. Sipe, and he can forward them. Other ones are the St. Louis test, the Montreal cognitive assessment, mini mental. So those are a little bit longer. But the tug-cog is kind of quick. You're already doing the tug with this older adult. And what you do for this one is you have them count backwards by 3s when they're doing the timed up and go. There's a couple numbers you could use. One is greater than 15 seconds indicates increased fall risk. Or if there's greater than 4.5 seconds between their tug and their cognitive tug, or 10% difference. So that may tell you that you need to work on them doing a functional task like walking or getting up and moving and thinking at the same time, so they can improve that ability and hopefully decrease their risk. So that dual tasking. Foot sensation, especially if somebody had cancer and chemotherapy. Chemotherapy-induced peripheral neuropathy is really, really common in people with cancer, and that increases their risk of falling. While there's not a lot we can do about it for interventions, we can help them to compensate using other balance systems. And you can get monofilament testing if you can order it from different websites, but it's just this one little plastic thing. You're gonna touch these different sites on the toes, and you also wanna check this for diabetics as well. It's 10-gram monofilament, and if they can't feel it, it means they don't have protective sensation, meaning especially if they have diabetes or chemotherapy, peripheral neuropathy, they're at a risk of getting a foot ulcer from stepping on something or not feeling a small rock in their foot, their shoe, whatever. On that note, I'm teaching integumentary this semester to my students, and one of my students said that she saw a patient in the clinic who was there for a post-ortho surgery, an ankle surgery. He took his boot off, and he had been walking on his reading glasses all day because he didn't feel it. I've had young patients with diabetes who I've one specifically who was hunting in the woods and went to take his boot off and it wouldn't come off, and it's because he had stepped on a nail at some point and his foot was stuck in the shoe because the nail went all the way through and he didn't feel it. So you can imagine, besides the sores and trauma, if you can't feel your feet, it can be a challenge to maintain your balance. For implementing the study, if you're doing it clinically, while the 3 questions are a decreased burden, you can have the questionnaire completed either online if you use online questionnaires before your patient comes in, or you can have the sorry, odd noise, you can have the administrator give the patient the questionnaire in the waiting room. The best way to implement clinically is really to get your electronic health record doing and facilitating you to do these things, as well as having champions. If you're doing it, the screening in a health center, you can also have your older adult do it as an intake form for you. So I talked about the study quite a bit, but there are other screening tools that you can use to indicate if you need to do more assessment. So Lasardi et al., along with Jerry Edge, who is an outcomes measure group for APTA geriatrics, this is a great article on outcomes measures, looked at many different self-report questions, patient report questionnaires, subjective outcomes measures, etc. And looking at that about 30% of older adults in the community fall each year. So that would be called our pre-test probability, meaning everybody's at that 30. Well, if they had a history and they say, yes, they've had a fall in the past 12 months, they're now at a 44% risk of falling. If they say no, they're actually lower than that 30%. So not much, but a little bit. Now note, if they're on those medications, if they need help bathing, dressing, or even if they say they're afraid of falling, then they're upwards of 38% as compared to that 30% baseline. So you can use multiple self-report or quick questions to ask to determine increased fall risk. On that note, the history of previous falls, I do think it's important to help older adults learn how to get on and off the floor safely. Now, that doesn't mean learning how to fall. Unfortunately, we can't really do that in research because there's no safe way to do that with older adults. You may ask about parkour, and I've seen people try and do that, but that's more with people who are higher functioning who can do those sorts of things. But if you think about some of the people that are falling, you know, some are lower functioning, some aren't. But with the risk of osteoporosis, fragile skin, and other things, we can't really, there's no way to safely teach anybody how to fall. But what we can do is teach them how to get up. My mom is pretty functional, but the other day she said she bent down to get something up and she had a hard time getting up. She's 65. And I was like, really? And she said, yeah, I don't know why. And I said, well, let me see how you did it. And she was making it so difficult for herself. I can't really explain how she was doing it, but it really wasn't a kind of normal movement pattern. But once I showed her kind of, okay, get down, get on your hands and knees, now get up to half kneel, and now go over to a counter or the couch and push yourself up. She's like, oh, that was so easy. Now I can get down and get back up, no problem. Also have some older adults who practice that every day because it makes them feel like a little bit safer should they fall. We still want to prevent falls, but of course, we may want to work on making sure they could get up after a fall. So on to assessment. For assessment, we want to look at our individual now as at a higher fall risk. Now we have to determine why and what can we do. And some things we want to look at are the balance system. So the balance system is extremely complex, and Erica is going to focus a lot more on intervention than I am, but I'm going to touch a bit on it. It consists of your sensory, somatosensory system, our vision, and vestibular, so our inner ear and our brain. There are many different types of balance. We've got static, dynamic, and if I'm anticipating myself moving, can I stop myself from over moving and not falling? Or if something comes upon me, can I react quickly to it? And then we've got balance strategies at the ankle, knee, hip, and stepping. But in order to be able to perform balance strategies and have balance, we have to have adequate range of motion. We've got to have adequate length at not just the joints, but at our muscles, tendons. We've got to have support with our ligaments. We've got to have adequate strength, motor control, power, So it plays into a lot of different things. It's not just simply balance. Now we can do evaluations and look at range of motion. We can look at muscle length. We can look at strength and power. I suggest you more look at strength and power in functional moves. We see a lot with older adults, people doing manual muscle testing, like just, you know, putting the leg in a position, pushing on it, and the person being able to hold it, but not sit to stand. That's because we're not taxing them to move it, their body weight against gravity. So try it in more functional ways. Again, falls on multifactorial. So we want to look at people's medical history. Osteoporosis is going to put them at a higher risk of fall and fracture. Again, depression, is it treated? And cardiac disease, is it medically treated? We talked about medication. I just talked about strength, balance, gait, and really function as well. I think feet and footwear are really underlooked at. One of the things I'm working on with a group right now is developing a feet and footwear screening tool for risk factors related to falls. So we want to look at the older adults. We talked about sensation, but how do their shoes fit? A lot of older adults like to wear bigger shoes. Their shoes are going to slip, their feet are going to slip in there, and it's going to put them at an increased risk. Is there appropriate tread on the bottom of the shoe? Can't be too much, not too little, because sometimes if it's too much, it can actually cause them to trip. Environmental hazards, so home, clutter, grab bars, rails with stairs, some of it is simple. And I would encourage any of you that work with older adults to look on that CDC Steady website. There's a great brochure an older adult can take home to check their home for safety. Simple things like removing throw rugs or tacking them down. A lot of having adequate lighting, especially at night lights, as well as even some older adults will like have a flashlight next to their bed. So when they get up to go to the bathroom, they can use it. We talked about cognition. Obviously, neurologic issues will play into falls, and vision. So if an older adult is falling and they use bifocals or trifocals, the research indicates that they actually should use one pair of glasses for reading and one pair of glasses for seeing far away to decrease their fall risk. As well as if you have an older adult that has cataracts, encourage them to get that surgery. It dramatically decreases their fall risk. Other things that you can do to measure lower extremity strength and power, a stair climb test, and there's some good values there with how you can perform on that, or a 5 times sit to stand rather than a 30-second, the 5 times a little more indicative of power. There's some cutoff values for you here as well. There are so many different outcome measure tools to assess balance and fall risk. The research, a lot of research is done on the Berg balance test. However, that's only for static balance and a little bit dynamic. There's no gait components in that. So if my older adult is losing their balance when they're walking, I have to use my clinical judgment that Berg isn't the best thing. But if I have an older adult that says they get dizzy or lose their balance when they're turning their head or when they're in the grocery store looking at the aisles, then that may indicate I want to use the dynamic gait index or functional gait assessment, because those are tasks that are performed in there. Another thing, if you're not sure which outcome measure to use, the mini best test is probably one that would target most balance impairments. There's an article by, now I can't remember it, but it looks at which outcome measures measure the multiple components involved in balance. And the best test measures all of them, but that takes 45 minutes, which isn't necessarily easy to do in a clinical or fitness setting when you're trying to do other things. So the mini best test is probably what I would recommend if you're not sure what to use. That being said, clinical judgment, don't always use the same tool with every person. I'm going to quickly go over this, but there are many other different tests, and the cut points are here for you as well. Don't forget about gait speed. Gait speed is a great predictor of so many different things. So just it's just their speed walking. in meters per second, and it tends to be tested at 10 meters that you would test it, but you can do it as small as 3 or 4 meters. Anybody who walks less than 1.0 meter per second at their usual gait speed is at an increased risk of falls. But you can see that they're also at increased risk of morbidity, mortality, disability, as well as nursing home placement. So it's not that we can just go, oh, you're walking slow, we need to teach you how to walk faster. There's probably multiple issues there. It could be cardiovascular, so we may need to work on their endurance. It could be musculoskeletal. There could be many factors, but we need to determine what do we need to work on. Just like I talked about the self-report items, there are different balance tests that also show you post and pre-test probabilities there. There are also self-report questionnaires that you can have people fill out that indicate a risk of falls. So there's many different things you can use to assess. So what about interventions? For PT, we want to address the ones that are within our scope of practice, which are strength, balance, gait. I would also put in there power, joint range of motion, muscle length, etc. And in balance, remember, a lot of those musculoskeletal and neuromuscular components come in. That includes motor control, coordination, etc. We also want to correct any environmental factors to decrease our risk. If you look at interventions, home environment and home environment modifications conducted by an OT actually have the highest impact of decreasing fall risk. Now, exercise does as well. Multiple Cochrane reviews and studies show that exercise for strength and balance with resistance training, aerobic, and balance training decrease fall risk, even if you don't do a questionnaire to determine their actual individual fall risk and the factors. So as we know, exercise is good, multi-component exercise is even better. Before I forget, don't forget about some of your older adults who are very active. We do find that some people who are high functioning are still falling, and the reason is they put themselves at higher risk behaviors. That being said, don't forget to really do prevention with everybody. And I especially see this in my older gentlemen who are out there still, you know, doing stuff on the roof, obviously not that safe, climbing tall ladders, doing some pretty intense yard work on very uneven surfaces, hunting. While those things are fine, we can certainly help them be as safe as possible when they're doing it. So what about exercise dosing? I'm only going to go over this briefly, and I'm probably talking to the choir here. But what I would like to say also is, as far as PTs go, we're going to get our patients as functional and independent as possible. But a lot of times we don't get to do this type of exercise dosing with them because we see them because they can't do this, right? So we're seeing them where they can't even stand up from a chair or walk safely. And we've got to work on those first before we can necessarily do higher intensity and appropriate dosing. But we want to start it as soon as possible. And that's where that's that great handoff to an exercise specialist to say, all right, they're independent now. I think I've addressed that impairment that isn't allowing them to be independent, but insurance isn't going to cover me to advance their function and strength or advance them further. So I need that exercise professional and that collaboration to work on that. But we want at least, you know, we're following the ACSM guidelines basically. And it's the same for older adults. We just have to consider any comorbidities and especially consider any medications that might be affecting heart rate, you know, as far as aerobic activity. I'm not going to go over this because I'm assuming that we are all on the same page. I'm happy to, if I have time at the end though. But what I do like to tell my patients is saying, like, you should be somewhat breathless when you're performing these activities, or Basically, I shouldn't be doing just 10 reps. I should be doing to fatigue. And if they can do 30, then maybe that's too much unless it's a repetitive activity. I want them to do a lot functionally. For balance, it is important though. They're supposed to do it about 25 to 30 minutes a day. And research shows they need 50 hours over 6 months of intensive balance training to actually decrease fall risk. What that equates to is twice a week, an hour each time, for 6 months. So that's certainly a behavioral change challenge because it also has to be challenging, but safe. And if it's challenging, it's not necessarily safe. So it's getting that happy medium. If they're going to do it at home, it has to be challenging. If they're doing it with you, it should be challenging enough where you have to be next to them. If they're doing it with you, that's what you're there for. So do some obstacle courses, perturbation training, meaning you kind of push them. You might push their trunk, their hips, their leg, so that they can learn how to gain their balance should they lose it. And then you also want to change their sensory input, closing their eyes, standing on different surfaces, walking or performing exercise outside on the grass, which is more challenging than on a level surface. We want to do dynamic. We don't want to do static balance. Static balance is not going to help them actually. So just standing, doing something on a cushion, it may help a little bit with their vestibular system, but it's not necessarily going to help with their dynamic balance. So again, task specificity. We want to encourage non-linear movements. So a lot of us get stuck in that linear movement. So during head turns, bending over, not just forward, but to the side, and doing a lot of those rotational activities, and maybe while they're walking forward, turning their head, carrying objects, especially grocery bags or things that they're going to have to carry at home, and just make them heavier. You know, laundry baskets, if you're doing back or extensor exercises, a laundry basket with increased weights. So we want to challenge all the different balance systems as well as challenge their the way they're walking. It would be sidestepping, walking backwards, turning their heads, targeted stepping. So stepping strategies, so stepping to an object is really beneficial, or a target. Those decrease fall risk, that type of intervention over and over. There's a really good app. I'm not getting paid for this and I don't have any stake in it, but there's an app called Clock Yourself that was developed by an Australian physical therapist. Meg Lowry is her name. And it can be used with older adults and anybody, even high level athletes, where it's working on targeted stepping. It includes some cognitive tasks and gets more and more challenging, but it's also fun. I really like that. So as they're able to do it, you want to add cognitive, manual, or visual components. So we don't just want to focus on walking, but we want to do, what do they do when they're walking in everyday life? Certainly we don't just focus on walking, and if we do, that means we need to get better at our walking so we can think about something else or talk to somebody or notice an obstacle and go around it. I'm trying to find my time here. We also can improve falls efficacy education. So what that means is, does somebody feel like they're not going to fall, or can they stop it? There are evidence-based programs that decrease fear of falling or improve efficacy. And one of them is called Matter of Balance. It's supported by the National Council on Aging. And it's like an 8-week program, but it's led by a trained leader that educates people on decreasing their fall risk, and it helps them to decrease their fall risk. It's available in the community. You'll have to look in your community to see where or if it's available. You can look on the National Council on Aging website. And this is for all evidence-based fall prevention programs or evidence-based exercise programs. You can look at your local senior centers, your departments of health, or your area agencies on aging. Those are usually the programs that get grant funding to implement these evidence-based programs. So that's not necessarily going to take away from you. It's just going to help your older adult to get better. Now, and since that's in a group, you still working with them one-on-one is is still going to improve them individually. So don't be afraid to refer them to an exercise program, or when they're not or discharged from you, to have them do it. Other recommendations, and many of us have, training in some behavioral change, because if we don't facilitate change, our people aren't going to adhere. So motivational interviewing improves exercise adherence. There are some free online courses through the CDC on motivational interviewing, and you can get an understanding of it. Excuse me, my battery's low, so I'm going to keep talking to you as I walk through my house to my plug, because I had to move due to my audio earlier. But that can help, although you do need quite a bit of training and mentorship to properly do motivational interviewing. Yoga can also be helpful, Tai Chi, as well as dance. So as you can imagine, movement in general and taxing your balance, as all of these do, can improve balance and decrease falls risk. I think the most important thing to note is to ensure that you have your older adult doing activities that they enjoy. Apologies for that. Activities that they enjoy. Thank you for your patience. So for those evidence-based programs, again, you can find them on the National Council on Aging website. It does matter how high risk or how frail they are as far as what exercise program would work best for them. And there are some good handouts that you could see. For example, Tai Chi requires people to be a little more functional and higher balance. Whereas the Otago exercise program, which is evidence-based and led by a physical therapist, is best for home care or people who are extremely frail. When should we refer to the physician? Well, when there's a medical issue, as I said. If there are vestibular issues that as a PT you feel are centrally and not peripherally located, any sort of neurologic issues, myelopathy that are not already diagnosed, and of course those cutoffs for blood pressure or heart rate, both at rest and with exercise. Some other referral opportunities are, as I said, for OT, home modification and assessment is a great intervention to decrease falls, but as you can imagine, it's just not very feasible or implementable unless somebody is already receiving home care. There aren't many programs where insurance will pay for an OT to go to a home and look at the home and for home safety. What I have heard about, and I don't know which insurance programs do this yet, but I have heard about some insurance programs having a nurse coordinator who every year would come to an older adult's home to look at it and review it for safety and review their fall risk factors. So I would encourage any older adult you see to call their insurance and see what their benefits are for that. Vision and cognitive screening, really your older adult needs to especially get that vision. Encourage them, make sure they do it yearly. And then the cognitive screening, we can only do a screen, but if we're concerned, send them back to the physician. And I talked about many of these others as well. If there are foot issues and you're seeing, if they're having pain in their feet, and it could be from skin changes, nail changes, it could be from bony changes, then refer them to a podiatrist, because addressing those will decrease their falls risk. I wanted to give you some tools that you could also use. This is from the Nsaids study, which was recently published. And what they have is a falls risk assessment and implementation plan for an older adult. So if the older adult is at risk and we note that they have changes in strength, balance, or walking, are they wanting to address it? So they may have all of these factors, but as you know, if somebody doesn't care or want to address it, it may not be feasible or work for them. So this is looking at, here's their risk and what are they willing to address and how do they want to address it? Now, the results of the study actually showed that 100% of the older adults identified at risk had changes in leg strength, balance, or walking, and 95% of those older adults wanted to address that. So that's great for all of us, right? That's what we do for PT, for exercise specialists. Those are kind of our wheelhouse. So definitely potentially a way to get clientele, patients, and clients, even if you're doing a community screening. So this is where, and these are available for free online. If you look up the Nsaids study, their materials are available. You can Google it, or you can just screenshot this. This is involving that older adult in a plan. How are they going to address it? What do they want to address? And you help them. So it's not just them doing it. It's us helping them determine what's going to work. As we know, if we want somebody to do certain exercises, but they don't find them important or they find them uncomfortable, it's not going to work. We've got to work with them. These are also online. From another talk I did, I was looking at some actionable plans that people can put in for self-behavior change. So I liked this Smart Health Action Plan. I think it can be used for anyone. Again, this is helping them make their own goals. And there's your reference, as well as this one. I really like it. Again, I told you I like blue and green, so that's probably why. But I like the way it sets up your client. Why is this important to you? It's almost a little bit of motivational interviewing on paper. Another thing the CDC has that's really helpful for a plan is the My Mobility Plan, and you can find that online. It's aimed at older adults, and sorry, I didn't have the full PDF in there, but it helps them develop a plan to manage their personal health and independence, home safety, as well as a plan to get around should they not be able to drive. Again, that's free online and it's really beneficial. There are different ways to implement the study. The CDC has a very large resource here in the coordinated care plan, and that is more in use for clinical application, especially in primary care, but it really helps to implement it. There are many resources to help fall prevention in older adults, so that's just one of many that I showed you, the study and the CDC resources, Nsaids. We have quite a few on our website. The APTA, Geriatrics Balance and Falls SIG, we've developed a falls prevention awareness toolkit for clinicians and or other professionals to use to conduct community screenings and outreach. It's free and downloadable. You don't have to be a member of the APTA. We've also got an outcomes measures toolkit. If you are wanting to find out what's going on in your state, you can look at the APTA state advocates, geriatrics. They're usually involved in those types of activities. The Fall Prevention Center of Excellence has a lot of resources, especially in home safety. And then you can become involved in your state's Falls Free Coalition as well. So here's all the references. I wanted to open it up for discussion or questions, please.
All right, well, Jennifer, thank you so much. That was great information, and I tell you, it's just so needed. So many, that's there's so many great resources that are available, evidence-based resources that one of the problems, it just doesn't get out to people. Right? So many professionals don't know about these great resources. So it's awesome that you have all these things kind of linked in there. I'm going to ask you something that you mentioned very early on. And by the way, very nice balance. I'll put you at low fall risk, the way you navigated your house.
Thank you.
Different, you know, you're handling multiple cognitive tasks at the same time.
And manual, right?
That's
Yes.
right. You were doing it all.
Yes.
That's great.
That's right.
But yeah, I kind of thought it was funny if you fell while you were doing that. That would be
That would be funny. Yeah.
No, but going back to what you were talking about very early on about kind of the interface and the connection between the therapists and the fitness professionals, you know, and your comment was like, man, if I had a fitness professional that I knew was really competent working with older adults, I would work with them. Talk a little bit more about that. Like why,
Yeah.
well, how can that happen more, especially related to balance and falls?
Yeah. So for me, and having, got my PT degree and then my exercise science degree, made me look at things differently. And I can tell you most PTs feel, okay, we're good at the impairments. So let me say where we see we fit in. We're good at, you can't do this. We need to help you do this so you can be independent. So that could be vestibular, it could be balance, it could be, the number of things I already talked about. But most PTs aren't good at exercise dosing. They're not good at pushing those older adults beyond that independence, and they are to a point, but where they have to be over their reserve, right? Because they don't have a lot of reserve. So most PTs, I hope, would say, and the ones who are good would say, yeah, you know what? I think you guys are actually probably better at that. My hesitation sometimes is I need to know that somebody's had training in working with older adults, because I've worked with some fitness professionals or even PhDs who maybe have an exercise science background, but have worked with an older adult on beta blockers and tried to increase their heart rate and make sure they were at like 60% of their max heart rate. And if you don't have that training, then you don't know that you're going to kill somebody, because the beta blockers aren't going to allow their heart rate to go up. So you can't go by their heart rate for their aerobic capacity and to increase that. So if there was a fitness professional that came and said, I work with older adults regularly. Here's how long I've been working with them. Here's my CV, and here's the type of people I work with and their diagnoses. And here's my the training that I've done, and here's what it involved. Then I'd be like, great, I can feel okay sending my older adults to you, because we hate that we have to go, sorry, we're happy you're independent. You need to keep moving though, and you have to keep progressing yourself. And most older adults just can't do that. Most people can't do that, right?
No.
So especially if you look up a GCS, so that's the geriatric certified specialist, or even, I don't know about ortho, I can't speak for ortho PTs, but if you look up those geriatric specialists, most of the time they're going to go, we just want what's best for our patient. We want to be able to hand that person off and know that there was someone who's competent and trained and is going to keep them going. We don't want them to come back to see us. We have enough patients, but we also want where that exercise professional says, you know what, something's going on, and it's kind of beyond necessarily, I don't really, know how to do central versus peripheral vestibular impairment evaluation or treat it. So this person needs to go back to this PT, and I know this PT is the one who can assess that and then get them better and still hand them back to me. Because I can tell you, we don't want to take the patients away. We're only going to have them for a limited amount of time.
Right.
So don't be afraid to refer. At the same time, like I said, most therapists want their patients to keep getting better, and we don't want to see them back, to be honest with you. Yeah. So it's just, I would say though, the fitness professional is going to have to reach out to the therapist. Mm-hmm. Therapists aren't going to reach out. And what's the best way to do that? It may be emailing, the management. It may be setting up a meeting and saying, hey, here's what I do, and being prepared to answer questions, being confident in your abilities, but also being very clear in your limitations, because we all have them. Yep. Don't be overconfident. I'm very clear in saying, my husband's like, my shoulder hurts. I'm like, let me send you to a friend, because I do geriatrics and neuro and wound care, and I haven't done ortho in 20 years. So I'm not going to try and do it.
And I would say, like, let's talk about a fitness professional who all of a sudden started referring clients to you because they're using some of these evidence-based screening tools picking up on things that are beyond their scope. And then, you know, you can still train what you can train, but refer on for evaluation, you know, for you guys. My guess is that you would automatically think, oh, this person, they're probably above everybody else, right? Yeah.
100%. But as a fitness professional, so if you're working with older adults, you want to refer your patients, unless it's a pure orthopedic problem, to either a GCS or an NCS. So that's, we do additional board certifications, and we have experience and extra training, and take another test years after we get our PT degree. That means that's what we specialize in. That's what we're passionate about. And as you know, there's some okay fitness professionals where you're like, well, they're just doing the reps and they're not really doing evidence-based. Well, it's kind of the same with PTs. There's some great ones and there's some ones who are doing it just for the money. So the ones who are certified usually are up on the evidence-based stuff and really passionate about what they do. And those are the two that would really know how to work the best with older adults.
Yeah. Well, thank you, Jennifer. Really appreciate your time and all the information today. I tell you, I'm going to really emphasize and encourage all of you that are listening. All those resources that she referred you to, I mean, those are rich resources. I mean, I'm a resource junkie. I've got folders and folders and folders of stuff. If you don't have this material, you need to grab it, you need to look at it, digest it a little bit, and then figure out, how am I going to implement it, right? There's no sense in kind of watching and listening and going, oh, that was great information, if you're not going to then get the resources and act on them. So really encourage you guys to do that and to start making connections both ways between fitness professionals and physical therapists. So Jennifer,
and then I'll put my email in the chat if anyone has any questions or wants to follow up.
Awesome. Thank you. Appreciate that.
Thank you for having me, and please do what you can to prevent falls. It can also get you more clients, because a lot of older adults are aware that's a big issue. So
yeah, definitely. All right, thank you. Hope
thank
you guys
you all.
Have a good day.
Yeah, hold on. Let me type in my answer here. I put it in chat, but I will put it in the Q&A as well, because it looks like there's more than one here.
Okay, sounds good.
Thanks for having me.
You're welcome.
I appreciate it. Have a great weekend, everyone. Thanks for going for a walk with me in my house as well. But it's funny that you noticed the fall thing, because that's the other thing. I'm glad you said that. Short side note, just watch, right? So you really have to be very observant. So sometimes when you're assessing or screening that older adult, they're doing their best because they know you're watching them. So watch them when they're just walking or not paying attention to you watching them, and you will probably see more imbalance and issues than when you're testing them. So yeah.
Awesome. Well, thank you. Appreciate
it.
Thanks,
everybody. Take care. How do you get the slides was a question. You can email me directly, since there's this, or Cody. Yeah, you can just email me directly if you want the links on the slides.
Okay, sounds good.
Thanks.
Thank you.
Bye.